Thank you. Good afternoon, everyone. Thanks for this nice introduction, and thanks for inviting me for today to stand here with you and trying to go over some new developments in relation to small molecule or molecular targeted therapies and refractory differentiated thyroid cancer. Indeed, by this time of the day, most of the things that you will hear in my lecture would be kind of repetition from what you have heard since the morning, so forgive me for that. I have no conflict of interest with any of the manufacturers of the drugs that I will mention throughout this talk, nor their competitors. It's clear for all of us at this time, as was emphasized in previous lectures, that the therapeutic goal of differentiated thyroid cancers is to minimize the risk of recurrence. Given the fact that the vast majority of those differentiated thyroid cancers have quite good prognosis, this goal can be achieved by the initial standard therapy of adequate surgery, radioactive iodine ablation, and levothyroxine TSH suppressive therapy. But in some clinical scenarios, the patients can present with differentiated thyroid cancers with more aggressive course, that is metastatic or refractory to radioactive iodine, and few therapeutic options will remain at that time. So radioactive iodine resistance differentiated thyroid cancers carries high mortality, as was explained by Dr. Hajat, and around 50% of patients with metastatic refractory disease, they die of their disease. Their median survival is 3 to 6 years, and improved survival is associated with responsiveness to this radioactive iodine therapy. Unfortunately, 15% of patients with differentiated thyroid cancers metastatic disease have refractory disease to radioiodine. Moreover, oncogenic mutations in BRAF and BRAF also carries worse prognosis. So if that's the case, they have worse prognosis in terms of progression-free survival or overall survival. So questions will come in that scenarios. What would be the most proper management for metastatic disease? What's the role of external beam radiation therapy or role of conventional chemotherapy? And what's the role of the molecularly targeted tyrosine or multikinase inhibitors? So over the next 20 minutes or so, we'll try to touch base on external beam radiation therapy in metastatic differentiated thyroid cancers, conventional cytotoxic chemotherapy, and I'll devote the big bulk of time for the molecularly targeted therapy, specifically the small molecule kinase inhibitors, whether tyrosine kinase or multikinase inhibitors, because there is more evidence for their role in differentiated thyroid cancers compared to monoclonal antibodies and mTOR inhibitors. So, in recurrence disease of differentiated thyroid cancers, the first response would be combination of surgical re-exploration, if it is operable disease, and radioactive iodine ablation. And if the case or the disease thought to be inoperable or refractory to reactive iodine, then other measures can be considered, like external beam radiation to control local neck disease or to target certain metastatic disease in bone or in the CNS system. If the disease is stable, slowly progressive, asymptomatic, then watchful waiting would be a reasonable approach. We're talking about metastatic disease. In case of rapidly progressive macroscopic refractory disease, then according to the NCCN and expert opinion recommendations, that patients try to enroll your patient into experimental trial, and if that's unavailable, then try to initiate the patient on any of the anti-proliferative agents like tyrosine kinase inhibitors or the multikinase inhibitors. In certain situations, other options like radiofrequency ablation, chemoembolization can be helpful for cases of liver mets or metastasis to the bone. Percutaneous ethanol ablation might be helpful for metastatic cervical disease less than 1.5 centimeters size. And surgical therapy might be also an option to prevent certain complications at targeted sites like CNS mets or central neck compartment. So keep in mind that watchful waiting might be an option in metastatic disease in patients with local asymptomatic disease, or in patients even with distant METs but had no symptoms and those METs are not involving the CNS system. Here are some caveats regarding the bone metastases and presence of a thyroid nodule. So whenever there is a distant METs and presence of a thyroid nodule, the physician is allowed to think that the thyroid cancer is the origin for those METs, but we should not jump into conclusion before confirming the diagnosis with a biopsy from the MET site that shows thyroid markers by immunohistochemistry. The role of external beam radiotherapy, there might be a role in patients above age of 45 with papillary thyroid cancers with aggressive variants or with soft tissue invasion. So in case of metastatic disease that is refractory to radioactive iodine, the role of external beam radiation exists. It might be also used as adjuvant therapy post complete surgical resection to prevent or minimize local recurrence of disease, or even in presence of incomplete surgical resection to provide regional or tumor control. Palliative therapy can also be considered in patients with distant METs. It's important to appreciate the interplay between some systemic agents and the efficacy of radiation. So it is well appreciated that some agents like gefitinib, which is a receptor tyrosine kinase inhibitor, will enhance the radiation sensitization, so it makes it more sensitive and more effective with more tumoricidal effect for the external beam radiation therapy. Unfortunately, the majority of histological subtypes of thyroid cancers have poor response to conventional cytotoxic chemotherapy. Doxorubicin is the only FDA-approved cytotoxic agent for metastatic thyroid cancer. The clinical response is usually partial, short-lasting, associated with toxicities. Other agents like cisplatin can be considered in patients who doxorubicin is not an option. And the combination with those agents, along with doxorubicin, have no superiority on treating patients with doxorubicin alone. It will just increase the toxicity. So now let's just rehearse on something that you've heard throughout the lecture. So this figure shows the tumor cell in a thyroid cancer. This is the cell membrane and this is the nuclear membrane with upregulated tyrosine kinase receptors, the RET, the EGFR, and the vascular endothelial growth factor receptor. And those are tyrosine kinase receptors. And this diagram here shows the normal signaling transduction pathway of those receptors. Those are glycoprotein membranous receptors with a ligand binding site and transmembrane site and or cytosolic site with a catalytic activity. So this is the domain with the tyrosine kinase activity. Upon binding of the ligand to its receptor, there will be a dimerization of the monomers with the cross-phosphorylation that will enhance the ATP binding to the catalytic domain and recruitment of other substrates to the catalytic domain, and that will initiate the downstream pathway. So the effect, or how kinase inhibitors, or they call them small molecule kinase inhibitors, act, basically they will just prevent the binding of the ATP and other molecules to the intracellular catalytic domain of the receptor. Now that effect can be either on a tyrosine kinase receptor, so they can be selective tyrosine kinase receptors inhibitors, or it could be on a serine or threonine kinases like the RAF or the MEK inhibitors. So that we have selective MEK inhibitors, for example, like ciliotinib, or mTOR inhibitors. Or like the case of sorafenib, they could inhibit multi-targets like tyrosine kinase as well as RAF kinase inhibitors. those are the major pathways identified in relation to the cell-related signaling pathways. So it's the RAS, RAF, MEK or MAP kinase pathway, and the PI3, AKT, and the mTOR pathways. So those can be inhibited, as I said, like either selectively, like by inhibiting the intracellular site of the receptor tyrosine kinase, or by inhibiting the BRAF kinase or the mTOR inhibitors. Moreover, they also can be inhibited by antibodies, monoclonal antibodies that will bind and neutralize the ligand, preventing it from binding and activating its receptor. So tyrosine kinases play a major role in the carcinogenesis of thyroid tumor cell. So it induces the proliferation, angiogenesis, and invasiveness and metastasis. And that can be inhibited, as we said, by tyrosine kinase inhibitors or monoclonal antibodies. New therapeutic options in advanced or for advanced forms of thyroid cancers. This is the title of a review article published in Expert Opinion online this month, March 2014. They did a search till October 2013, and it revealed 23 active trials in relation to systemic agents and thyroid cancer management, out of which 17 trials were concerned with the differentiated thyroid cancer, which is our interest today. The PubMed search revealed 2,291 articles related to thyroid cancer treatment. 73 of those articles were thyroid cancer and kinase inhibitors related articles. And 26 of those 73 were only published in the first 10 months of the last year, 2013. So definitely I'm not going to go over those 26 articles in this short time, but just to raise the point that it's a really rapidly expanding and competitive field of tyrosine kinase inhibitors and their role in thyroid cancer. In endocrine tumors in general, several molecules have shown their efficacy in terms of progression-free survival in phase 3 trials. For example, vandetanib and cabozantinib in medullary thyroid cancers, sorafenib in differentiated thyroid cancers, and everolimus and sunitinib in gastroenteropancreatic and neuroendocrine tumors, and so. I'm just repeating how the anti-proliferative properties of those kinases can be inhibited either directly by inhibiting the small molecule kinases through receptor tyrosine kinase inhibitors or MAP kinase inhibitors like selumetinib, or the MKIs inhibitors like sorafenib, multi-kinase inhibitors, or the mTOR inhibitors, in addition to the monoclonal antibodies like bevacizumab. This table shows phase 2 trial studied kinase inhibitors with their targeted target kinases, tyrosine kinases, and it just tells you that sorafenib is the only BRAF kinase inhibitor available in the market so far. Several phase 2 trials have been published showing the efficacy or describing the efficacy of sorafenib in differentiated metastatic thyroid cancer. And then we're going to come to the summary of that. Sorafenib is the first oral multi-targeted kinase inhibitors. It's a BRAF kinase inhibitors. After its approval in 2005 and 2007 for hepatocellular carcinoma and renal cell carcinoma, it got approved last November for the treatment of radioactive iodine-resistant differentiated thyroid cancer. And this is based upon the results of the phase 3 trial, the decision trial, which showed a substantial prolongation in the progression-free survival. So it increased, there was more, by 5 months more progression-free survival compared to the sorafenib group compared to the placebo group. So several phase 2 trials have been published regarding the efficacy of sorafenib, but the results of those studies haven't been compared till we came across this nice meta-analysis that was published last month, February 2014, in the Oncologist Journal. So they involved 7 trials, they were all phase 2 or trials with a total of 219 patients, out of which 159 cases of differentiated thyroid cancer. The inclusion criteria was studies of adult patients who utilized sorafenib in a dose of 400 milligram twice daily initially, and it's a studies who had standard reporting criteria for both response and adverse events. All the papers utilized in this meta-analysis utilized the same criteria for assessing tumor response, and they excluded other studies that reported on other agents or other type of cancers or phase 1 or case reports or review articles. So this table shows the results of the response in relation to sorafenib, the overall response, and so the response was interpreted as partial response or stable disease or progressive disease in all type of cancers or in patients with differentiated thyroid cancers. This is which is highlighted in red here. So the overall response the overall partial response for all types of cancer was 20%, as well as in differentiated thyroid cancer. The overall response for having stable disease in all types of cancers was 60%, and in differentiated thyroid cancer was around 58%. And the overall progression of the disease in all types of cancer was 20% and 21% in differentiated thyroid types of cancer. Of course, no study reported complete response to sorafenib treatment, and the overall median progression-free survival from all the 7 trials was 18 months for all types of cancers, including differentiated thyroid cancer. This table shows the major adverse reactions in relation to sorafenib therapy. More than 70% of patients experienced hand-foot syndrome and diarrhea, and more than 50% of patients had skin rash, fatigue, arthralgias, and weight loss. Cardiovascular complications included hypertension in around 36% of patients in the 7 trials involving the meta-analysis. So the adverse effects, those are the common as we listed them: the hand-foot syndrome, diarrhea, and skin rash. 6 patients developed cutaneous squamous cell cancers, and 8 reported deaths not related to the disease progression were reported. Approximately, because of the side effects, 16% of patients discontinued their medication, and another 56% lowered their dose because of toxicity. The most mode of lowering the dose or changing the dose was 400 milligram once daily from twice daily. They concluded in the study that treatment with sorafenib in patients with progressive differentiated thyroid cancer is a promising strategy, and adverse rate is high, leading to high rate of dose reduction or discontinuation. This is why careful selection of patients and management of their side effects is crucial. An alternative way to interrupt the downstream pathway of vascular endothelial growth factors or the receptor tyrosine kinase inhibitors, receptor tyrosine kinases, is the mTOR pathway, the PI3-AKT-mTOR pathway. I'm mentioning here the anti-proliferative and the immunosuppressive effects and anti-angiogenic. So the anti-proliferative and the anti-angiogenic were shown in studies studying the neuroendocrine tumors, gastroenteropancreatic tumors, but their effect, the effect of everolimus as mTOR inhibitor in relation to thyroid cancer is still controversial. This is a multi-center phase 2 trial of everolimus in locally advanced or metastatic thyroid cancer of all histological subtypes. They involved 38 patients with thyroid cancers of any histology that cannot receive or resistant to radioactive iodine. They received everolimus in a dose of 10 milligram daily and for up to till acceptable toxicity or disease progression occurs. The primary endpoint was partial response or stable response over 12 weeks. The disease control rate was 81%. The duration of response was 20 weeks. Stable disease reported in 76% of patients, progressive disease in 17%. The median progression-free survival was 47 weeks, And most common treated adverse effects were mucositis, anorexia, and transaminitis. They concluded that everolimus had a limited activity and low response rate in locally advanced or metastatic thyroid cancer in general. We went through that pathway, it's just a repetition. Now, we know that tumor cell in differentiated thyroid cancers, in the progressive type of differentiated thyroid cancer, they lose their ability to concentrate iodine. And in preclinical trials, it documented that the pharmacologic inhibition of oncogenic BRAF signaling can increase radioactive iodine incorporation. MEK inhibitors might also reverse this radioactive iodine resistance. So recent studies documented that the MEK1 inhibitor, MEK2 inhibitor as well, selumetinib and dabrafenib, both were effective in reversing the radioactive iodine resistance state, with selumetinib more effective in patients with RAS mutation rather than BRAF mutation, suggesting a MEK-related effect. In a more recent study published last year in the New England Journal of Medicine, the selumetinib induced that incorporation of radioactive iodine also in BRAF mutated patients. So to conclude, resectable or radioactive iodine sensitive advanced differentiated thyroid cancer can be considered for surgery or intervention by radioactive iodine ablation. If the tumor burden is asymptomatic and stable, the metastatic disease, then observation might be a reasonable option to go with. Certain measures like external beam radiotherapy can be used in attempts to control disease with localized cervical area, or even as a palliative treatment for osseous mets. If significantly progressive disease of differentiated thyroid cancer, then systemic therapy and agents like whether tyrosine kinase inhibitors or multi-kinase inhibitors should be considered, and we should encourage patients to be enrolled in studies in that case. Having said that, keep in mind that the molecular targeted therapy, yes, they are effective, but many patients do not require treatment for years with this metastatic disease. So, and molecular targeted kinase inhibitors have side effects that impact quality of life and not necessarily prolonging survival. Again, sorafenib till this time is the only FDA-approved agent for advanced differentiated thyroid cancer, and careful selection for patients to be initiated on sorafenib and managing their side effects is something important that we need to pay attention to. And we hope with this rapid development in the research in the field of tyrosine or kinase inhibitors and differentiated thyroid cancer will be provided with an agent that not only prove the median or progression-free survival, but also the overall survival rate. So that's it for this talk, and thank you very much.